Thank you for your kind invitation extended to me for this conversation this morning. As it was said, we are going to be talking about COVID-19 case management and vaccine, which is the most updated topic of these days, the vaccine rollouts everywhere in the world and the different challenges that we are encountering. This conversation is going also to base a bit on what we know from the past, because we realized by the end of it that we are struggling with, we might be struggling with problems that were there since long ago. And we are just updating our responses and recalibrating to meet the current realities. Next slide, please. I always use this slide so that we reflect together, and this has been helping to put us on the same page as we move and navigate through the presentation. And the slide is also to instill some conversations on what we can do better. You realize by now that we are not equipped with the same knowledge, though we are being affected by the very same problem of COVID-19. We have people like this young girl that I met a few months ago in the southwest of Rwanda, who had no idea what we are doing, but I'm sure what has happened today is going to affect her for quite some long time. We all have stories how we went into this pandemic, how it affected our neighborhoods, how it affected our families. I believe there is no person who would claim to have not been affected in any way by now. Some of you have lived long enough to see similarities with other pandemics or epidemics that you have had in the past. But we agree that our trajectory of life today has been changed by the global health threat of COVID-19. Next slide. What we do today when we say to someone that you are positive for COVID, it sounds a very short sentence, but behind that there are many scientific whys. Why am I positive? And I use these cartoons to highlight some of the key features of this virus, which is in the center, as you see on the left lower cartoon. It has a genome, which is an RNA virus, and it has around it different proteins and structures that keep it intact. And from it has its virulence to enter the cell and multiplicate. So when we say someone is positive to COVID-19, it means that the laboratory work that has been done has identified some unique structure or unique proteins in the samples that we are collected, be it nasopharyngeal swabs or pharyngeal swabs, sputum, and others, that we are unique for this virus. And this means these ones that are highlight ORF1ab, RDRP, which is inside the virus in the nucleus, E, which represent the envelope, and N, which is also on the surface of the envelope. Of course, the virus has several other structures that are shared with other viruses, but these four ones are unique for SARS-CoV-2 that cause COVID-19. And when we say someone is positive, we would have identified 4 of them here in Rwanda. And the vaccine engineering also is built on this structural description of the virus. And there are different ways of creating a vaccine by having the entire virus inoculated to someone in a very attenuated form, of course, so that it does not cause the disease. Part of the virus can be used, or the use of the inner part of the viral particle, which is the viral genome. Next slide. Same cartoon shows the interaction with the SARS-CoV-2, the virus that caused COVID-19, with the host cell. It is a very complex mechanism to have this virus enter the cell and multiplicate, starting by fusion, by releasing the nuclear component of the virus and the replication and repackaging of the viral particles to be released and infect other cells. On this as well, we base on this to engineer therapeutics and even vaccines, because when we say someone has developed antibodies, the antibodies are here to block the virus from entry into the cell by inhibiting this phase of fusion. When the viral particle goes into the body, the antibodies will just attach to it and not enable it to enter the cells and multiplicate. So that's the benefits that we expect or we gain from vaccinations campaign, like to inhibit the fusion or inhibit the internalization of the viral particle into the cell and destroy it. Next slide. So why would we spend a lot of money on vaccines? It has been a conversation. Why people who have not much money or other public health threat would still want to have a vaccine? You remember in March last year when we started this pandemic in Rwanda, when we got affected, the question that was being asked on daily basis, people would ask us, when do we have drug for it? When do we have vaccine? We are very lucky today. The conversation is about the availability of vaccine, but they come with a cost. And it's for us to go deep in the matter and realize and communicate clearly that vaccination is one of the robust way to address this pandemic, regardless to the cost that it might come with it, because treating people with COVID has also a cost. So I put a case scenario for us to reflect together. A gentleman who's 56 years old, who had a newly diagnosed hypertension and diabetes, but also COVID-19. But unfortunately, by the time he got the diagnosis of COVID-19, he was already too sick and his blood oxygen level had dropped very significantly. Providing the best medications that were available as per the available treatment guidelines that are well researched, including the several medications that are listed on this slide, the patient did not survive. Within 2 weeks, this gentleman did pass away. And of course, the entire care that was provided to him came with a cost that was estimated to be about slightly more than 5 million Rwandan francs. Of course, we did not charge this money because COVID-19 treatment in Rwanda was initially free. It's only of recent that the insurance are covering for it. But if you look at this very simple script, you will find a lot of interventions that are coming with a cost, and putting that together, you should compare them with the gains from the vaccine. If you had to vaccinate this man of 56 years old with 2 shots of a vaccine that costs $15 each, probably he would not have died, and these 5 million and more would not have been lost on him, and in the end he would not have died, as we see, because he got sick at a time where the vaccines were not rolled out yet. He did miss the opportunity to be vaccinated and be protected. Next slide. In clinical medicine, we always wish that we can have patients very, very early in their diagnosis of COVID-19, but reality is complicated. However, we still tell ourselves and our collaborators, including the media, that we should work hand in hand and ensure that we can suspect who might have COVID on time. This is the early suspicion. You have seen in very recent past when we entered the winter season that the population was confusing malaria signs and symptoms with those of COVID-19. And since they are much more familiar with malaria, they will go for malaria tests and later on realize it was COVID-19. Of course, the media did help us to communicate correctly that we shouldn't confuse the two. The very moment we suspect malaria, we should also be suspecting COVID-19. Of course, the widespread of rapid diagnostic testing did help us with an opportunity to have an early diagnosis so that the treatment is initiated timely and the outcome is much better. Next. Now back in the history of medicine, we used to have the world of the past was very much hit by different sorts of very deadly pandemics. I just chose one of them to have this conversation so most smoothly. You might have had a disease called smallpox, which has now been eradicated thanks to the vaccination campaign for it. It was here as early as in the 4th century, and the causative agent is a virus called variola virus, and the people who contracted it by then, 30% of them would pass away. But then, at that time, vaccines were not known, and there used to be a practice called variolation, which means you take one of the pupils or one of the lesions of the infected person and you smear it on a healthy person, and you trigger a mild disease into that person so that they become immune to it. Of course, by doing that, there was a risk that the person would develop equally severe disease and pass away. If you compare the approach to smallpox before this practice of variolation, the death rate was 30%, but with the variolation, the death rate was much more reduced, but it was not 0%. And further development happened, and the cowpox inoculation was started, and today we have a smallpox vaccine, and that's how it got eradicated. Which means when you communicate with the population about vaccination for COVID-19 today, it should reflect in the past so that they realize what we gain when people are vaccinated. Next slide. So what do we call a vaccine? It's a product that should stimulate a person's immune system to produce immunity to a specific disease. We are dealing with COVID-19 disease. It has a vaccine. We are very much lucky to have the vaccine. So the gain should be our immune system is triggered, is familiar with the virus, and if ever we had to get sick, we should be able to handle it without further collapsing or devastating collateral damage. And by doing so, we reestablish health in its tri-dimensional aspect, which is the physical health, mental health, and the socioeconomic health. Next slide. Plague, it's one of the other disease. I put this cartoon so that you realize actually you have seen us in these PPEs, like the jackets, some in white, some in different colors with goggles and gloves. It is built on the costume that were worn in the past when the world was hit by the plague. This is a plague doctor. A doctor by then was known by heart, and he was very much well covered, and he had a stick or a cane so that he would not be touching the dead bodies. The plague is known to have killed 1/3 of the world population at that time. It's one of the deadliest pandemic in history of medicine. So of today, although we don't talk about much often, the world by year can be hit by 200 epidemic events, of course, of different magnitude. Some might affect some geographical areas, some might affect countries that are struggling with their health systems. Some might be small enough, some might be as big as we have seen for COVID-19. And COVID-19 is not going to be the end of it. It is now predicted that more than 70% of pandemics are going to be driven by re-emerging and newly emerging pathogens. some that we know already that had been extinguished and they decided to come back, and some that are going to be new to us. So the work ahead is going to require a lot more collaboration that are multi-sectoral, and the world ahead is going to be much more challenging to rebalance the health in the aspects of One Health. Next slide. Common infectious disease and vaccine availability. We have had different diseases, as you see on this slide. Some of them have vaccines as we speak, because usually to manufacture a vaccine, expect almost 2 years if you follow, of course, all the steps of vaccine manufacturing, like the safety measures that should be in place, the scientific review, the test for efficiency and safety and efficacy, and the post-delivery monitoring and unlimited rollout. So COVID-19 actually vaccine have come very far before we get vaccine, for example, for malaria, for the SARS that was striking in 2003, and many other diseases that I did not list on this slide. Next. Looking at SARS-CoV-1, this is 2003, and SARS-CoV-2, you would see on the right side of this slide that the identification of the causative agent. So the virus was reported the pandemic was reported to WHO in December 2019, and already in early January, the virus has been identified. If you remember what I said on the first slide, if you had to have a vaccine, first you need to identify the virus. If you have no idea how the virus looks like, if you have no idea about the structural proteins of the virus, then forget about the vaccine. So it's a lot of work to ensure that you timely identify the causative agent. Then you can start a conversation of manufacturing the vaccine. Comparing to SARS-CoV-1 of 2003, there was a bit of a delay from February when the pandemic was reported to WHO, then the virus was reported a month later in April. So sometimes you are good enough or you are lucky enough, if I might say, and you identify the pathogen early enough and you get the vaccine early enough, as we have seen for COVID-19. And sometimes you don't, even if you have identified the causative agent. If you look on the vaccine tracker that is publicly shared on the website, those who are in clinical trial, there have been more than 300 vaccine candidates, and among which 86 are in clinical testing and 13 are in use. Of course, we don't have the 13 available to us, but at least we are lucky that today we have some that are being shared to countries through platforms such as COVAX. Why do we have vaccines that are shared to us? Because the global health security is threatened. And there is a saying that is recurrent that as long as we are not safe, all of us, then no one is going to be safe. So it's in our all common interest to ensure that the vaccine development are available as quick as possible, and the rollout is happening at the pace that would protect everyone in this global village. Next slide. This is the phase. I wanted to highlight the phases. There are phases that are preclinical when you try the vaccine candidate in animals. Then there's phase 1 to phase 5. As you progress into phases, then you are becoming a promising vaccine. Once you pass phase 5 and you are rolled out under emergency authorization use, then the hope to control the pandemic is even much higher. Of course, as I said, we have 13 that are in use, but in Rwanda, we have had Moderna, Pfizer, and the two have a very complicated storage logistics. The Moderna, for example, it should be stored to minus 25 to 15. Pfizer, it's even much lower temperature, such as minus 80 to minus 60. So although these two vaccines are having high efficacy, but you can realize that not all countries, not all realities will be able to cater for such ultra cold chain demand. Then you have the AstraZeneca, which can be stored at a temperature that you can store at the commonly available vaccines in Rwanda. Next slide. How does the vaccine work? The mRNA vaccine, we have two, Pfizer and Moderna, and of recent we have the rollout was more of Pfizer. As said before, it's just transferring the genetic or the genome of the virus into the host cell so that the host cell can react to it and produce immunity to the COVID-19. It is a very good scientific theory behind it, but the storage, again, it's very challenging. The vector vaccine, it's when you take that viral genome and you transfer it to another harmless virus so that it can transport it to you into the host of the vaccinated person and produce the same effect. It's relatively easy. The cold chain is the same for other commonly used vaccine. So that's why you have seen AstraZeneca widely rolled out in remote areas, especially in countries that have logistics related to uneasy roads or proximity of where people live, uphill, and other realities that you don't want to be surprised on the road when you are transporting like a Pfizer vaccine, because if the road is blocked or there are delays to reach point A from point A to point B, then you can waste the vaccine very easily. So you have to ensure that you have maintained the ultra cold chain as stated by the manufacturing companies. Next slide. So what do we know today about COVID-19 vaccine efficiency? There was a correspondence that came, that was published in New England Journal of Medicine 2 days ago. And the question that was being asked is, how much of antibody response do we get after one single dose? Most of us might have had, some of us actually, might have had the first dose of Pfizer vaccine, and you are asking ourselves the same question. The answer is, actually, the antibody response in the people who were infected with COVID-19 is somewhat superior to antibody that someone who was not infected would get after one shot of mRNA vaccine. And the antibody against all the subunits or all the components that we are targeted, such as S1, S2, or receptor binding domain. So to put it easy, if I had COVID, I have a certain level of immunity. The problem is that it's not going to last for long. If it lasts, it's estimated that it can last for 3 months. Beyond 3 months, if you find yourself in an area that is very highly endemic or highly with high positivity of COVID-19, like in Gisagara or Nyanza or Bugesera today, you are likely to be sick again from COVID-19. Now, the antibody levels that you have having been exposed to prior COVID-19 vaccine are actually more than I would get if I never had COVID-19 vaccine. So which means that's a message for me, I still need a second shot. If I never had COVID before, I should get a second shot of the vaccine so that I'm equally protected. Next slide. Again, a correspondence. We have many correspondents nowadays reporting on the vaccine and answering to questions that we are asking ourselves regarding efficacy and the protection that you get after receiving the first shot or the second shot. As you can see on this slide, it's very easy to see the difference between people who are not vaccinated. They have high rate of COVID-19. They're at risk, highest risk to get the COVID-19 disease compared to those who have been partially vaccinated. I mean, those who have received only one shot. And also those who have been fully vaccinated, which means 2 complete doses of mRNA vaccine or AstraZeneca vaccine, they will be at a very lower risk to contract severe COVID-19 compared to the 2 groups. Next slide. Why should we share COVID-19 vaccine equitably? It's very easy. Remember last year in Rwanda, when the first case was registered, the first month, we really did great together. All Rwandans did contribute, and we kept our numbers low. Until June, when the cross-border movement from Tanzania triggered a community transmission in Rusizi. This was in June. Then our COVID cases quickly picked up at a very dizzying rate. And this always resurrected in me the need to repeat this quote from Peter Piot, that epidemics on the other side of the world are a threat to us all. No epidemic is just local. We might do great within Rwanda, but if in Tanzania by then you're having high rates of COVID, in a way or another, that disease is going to spill over to us. So we should see more of global collaboration, not very limited geographical entities working great in their small corners. It should reflect in the region, on the continent, and globally. SARS-CoV-2 does not respect borders. It moves from a country to another along with the population movement. You have seen that for different reasons, people can go to Tanzania, to Congo, especially for commercial purpose. People can come from outside to Rwanda, or we can transport goods. You know that the virus can resist on solid surface for a couple of days. So through these movements, as we ease restrictions, we are also seeing the virus being transported from point A to point B. So if in those points we have been vaccinated equally, if we have been following the precaution measures equally, then you would say that we are at the lowest risk. But as you cross from entities, countries, and continents with different perspective on the virus, then the risk are going to repercuss back on us. Vaccinating one part of the world or one country or one continent is very dangerous because you are giving a chance to the virus in a country that has not been vaccinated at set threshold to mutate, and mutation by the end of the day are going to be more deadly and spill over to different countries and eventually circulate globally and invalidate the efforts that you have done prior to vaccinate at a rate of 100% in a certain country. So it's going to waste their resources in some way. So it's not about 60% of a country that should be vaccinated, it's 60% of the global population, and this should happen at the same pace. Next slide. Vaccine rollouts have very significant logistics that should be accounted for. We can use the 4S just to recall some of them. You need staff, doctors, nurses, security organs. You need to escort this vaccine because if you don't, they are going to be stolen. The car are going to be stoned. If they reach an area whereby they don't like the idea of vaccine, you might end up in a problem and many losses. You need people to volunteer. You need pharmacists, the administrators. You need a journalist to be sure that they have prepared the population, that they have addressed all the rumors, and they have provided all the scientific facts on what is being done and answered to all the whys. In Rwanda, we needed the pilots to drive these military helicopters to transfer the vaccine to a bit of remote areas like Rusizi, to reach Rusizi in a shorter time, especially that you are transporting something that is very time sensitive in terms of the cold chain requirement. You need the needles, the swabs, the ambulance, the vehicles to transport the vaccine from the district hospital to the health centers. You need space for storage. You can't store 13 million of doses of COVID-19 vaccine in Rwanda. I don't think we have that space. So it's going to be a phased or a gradual approach. You store, you deliver, you store, you deliver until you complete. That's why the Honorable Minister of Health said by the end of 2021, 30% are going to be vaccinated. By the end of 2022, 60% of the Rwandans will be vaccinated. If we get to these goals much quicker, good for us. You need space for people to sit as they wait to be vaccinated, as they are being provided information, as they get observed after getting their jabs. Then you need system. System is very key. You need to collaborate with others. This is not a problem that was just left to the health sector to be handled. It's a problem that has been handed over to all of us, the private sector, the journalists, the media group in country and overseas, the religious leaders, the local government, the municipal leaders, so that we collaborate to make sure that if we say we meet to this place on this date at this time to receive a Pfizer vaccine, it should happen. If there are delays that we have not addressed or people that we have not approached or discussed with them beforehand, then we are going to create a lot of logistical nightmare. Good enough, it did not happen in Rwanda as for now. Next slide. Vaccine hesitancy. You have surely heard of this term, whereby you call someone very well listed as number 1 or number 2 to come on point A at this time for vaccination, and they don't show up. Or when they show up and you try to talk to them about the vaccine, they're consenting, they refuse to sign, and they go home without hesitancy. It's not a unique phenomenon for Rwanda. It's a phenomenon that has been there for a while. But in Africa, it was a bit of less because we see people refusing vaccines in some countries in Europe because of their beliefs and their social circumstances that we cannot go deep in that. But in COVID-19, vaccine hesitancy has been there. You see people who refuse. You see people who refuse but not sure if they should refuse. You have people who accept some, but they delay and refuse some other vaccines, or those who accept, but they are not sure if they have made the right decision. So that's all of that is called vaccine hesitancy. Then you have, of course, the good people who have been briefed, who have been following what is in the news, who have been provided with scientific fact, and they accept with a smile. In societies where there is a lot of vaccine hesitancies, there are ways to go around it by, for example, giving the example, if you're having the opinion leaders stand on your side and show the population that they are being vaccinated also on this at the same time with them. This can increase their confidence into the vaccine, and the rollout of vaccine is happening faster and as far as it can go with a high level of acceptance by the population. Next slide. Group work. There is something that we need to do together. If you don't mind, you have heard that some districts of Rwanda were excused to remain a bit by themselves so they can reflect and recalibrate their COVID-19 response plan within the district in what we call Guma Mukarere. And this slide, this was tweeted, was shared publicly by the Rwanda Biomedical Center on their Twitter. So that is very transparent why those districts had to be excused in terms of movements, restriction, lifting of the restriction is because they had the high positivity rate in the survey that had been done before these decisions were done. And the top district that we are going, all of us in there, finding the biosocial analysis of the problem and propose solutions. Why do we have an 11% positivity rate in Bugesera, for example? Of course, there must be a reason. There is a reason that are not easy. It requires people's work, going there, having a conversation, sitting with them, documenting, triangulation, group discussions until you find the right problem. Then you can prescribe the right remedy for that. Same for Nyanza, same for Gisagara, Ruhango, Nyaruguru, Huye, Goma, and Nyamagabe. I used to visit a bit Nyamagabe in the COVID pandemic when I was still posted in the Western province. For example, I know that they like sorghum beer, and sorghum beer is part of their life. They like to go into very cozy rooms and enjoy sorghum beer from morning to evening. That could be one of the whys. They will have higher rates of COVID-19 cases compared to others. And it's our responsibility to go and sit with them and analyze the problem and discuss and obtain their views. And we decide all together what is best for all of them. Next slide. this is to thank you. And as soon as this problem is over, I think we'll be able to move around unrestricted and visit the beautiful Rwanda. This is a town of Karongi in the western province of Rwanda. Until then, please keep your mask up. I thank you very much, and I welcome questions. And thank you for the invitation. Thank you.